So, my name is Surbhi Phatnani. I'm currently a second year med school student at the New York Institute of Technology, College of Osteopathic Medicine in Long Island, New York. I was a biology and anthropology double major in college. And I'm going to be giving a talk about the intersections of pediatric mental health and single payer reform. So let me just get my slides here. Um, All right. Can everyone see my screen?
Yes.
Okay.
Yes.
All right. So, why do we care about this topic? So, I have a personal connection. This is actually my brother. His name is Divyansh. He is a 21-year-old. He has severe, profound autism. I'm originally from Massachusetts, and he receives care there. So he has concomitant autism, ADHD, and OCD. And for Massachusetts, the Medicaid version is Mass Health. It's actually pretty comprehensive. It covers a lot of different mental health services, physical health services. It's really good for also new refugees who arrive here to the United States. They typically are on Mass Health. Um, and because he's actually covered under both Mass Health and my mom's private insurance, Mass Health does provide some reimbursement to us for not using all of the services that it provides. Although Mass Health is pretty comprehensive, there are some barriers. So, for instance, neuropsychological testing, it's traditionally covered. However, we wanted to have Divyansh see the best neuropsychologist who specifically specializes in autism, and he did not take Mass Health, and each visit averaged about $4,000. These are about yearly visits. And then applied behavioral analysis, or ABA, is basically a form of behavioral treatment to help individuals with autism and learning disabilities learn skills. And traditionally, these are provided both in the school setting and at home and in the community setting. And again, the out of school ABA treatments are covered by Mass Health. However, it's very incredibly difficult to secure them because there's been a shortage of ABA teachers, who are working outside the school setting. And we were not able to find one through Mass Health, but even privately, it was very difficult for us to find them. We had to do a lot of advertising, asking around, networking to find teachers. And we've been fortunate enough to secure high quality care for my brother, but not everyone is able to. And I wanted to also preface that private ABA therapy, my mom has been paying about $50 to $75 an hour. So a lot of these costs really add up. So Mass Health isn't working as smoothly as we would like it to. The next thing I want to talk about is the parity law. So this was enacted in 2008, and it states that the financial requirements like deductibles, copayments that are applicable to mental health or substance use disorder are no more restrictive than the financial requirements that are required for medical and surgical healthcare needs that are offered by a plan. So while it is proclaiming that there is kind of no discrepancies between the cost coverage for different health services, um, the cost that an average American pays is actually still pretty high. So an average yearly cost for healthcare is about $1,142, and then the average medical debt per year is $3,100. So even though mental health is now on par with surgical and medical health on the books, it is still very expensive, as traditional medical care has always been very pricey, and so thus mental health is also very pricey. And there's also this law also doesn't cover that for certain insurance plans. For instance, there is a cap on a number of psychotherapy and psychiatric visits, whereas for other physical health ailments like, for instance, COPD or congestive heart failure, there isn't a cap on how many times you can see your provider. whereas for mental health, there sometimes is. And after that cap has expired, like the provider has to put in a prior authorization for additional services. So I'm not sure, it really isn't true parity. And there's also no rule or law that states that every insurer has to provide some kind of mental health coverage, which I will discuss more in the next slide. So this is actually my friend, Mariana from college. So before the age of 25, she was under her mom's healthcare plan, and it did not cover mental health whatsoever. So no therapeutic medications, no psychotherapy, any mental health services were not covered. And she had in the past been diagnosed with certain learning disabilities by a primary care provider, but the only thing she was able to get for that were accommodations at school. She actually got her first mental health evaluation when her mom changed jobs and she turned 25. And she got diagnosed with anxiety and ADHD. She got therapy and medications, and she's been doing much better. And there was also a recent kind of lapse in her insurance when she turned 26. She lost coverage. So for 3 months until she changed jobs, she was not able to access any of her mental health services, and she really struggled during that time. So this just really goes to show you that even with the parity law, there are still gaps in coverage for people. There's no mandate to have mental health coverage. And there's also been great benefit to having early intervention for mental health treatment. So the earlier individuals get them, the better they cope later in life. And, this was for Mariana, she had later access to coverage as well as a lapse in coverage eventually. So the current system really did not serve her well. And I wanted to talk about the movie Inside Out, which just came out this past summer. It's about an 11-year-old named Riley who moves to San Francisco. She is competing in some hockey tournaments, ice hockey tournaments, and she just finds out that her friends are going to be changing schools. And throughout all this time, a new emotion emerges, anxiety, as well as ennui, embarrassment, and jealousy, or excuse me, envy. And all of these emotions are really kind of creating some negative feelings and kind of struggles for Riley, but they are also informing her of certain things that are going out in the environment and changes that are happening. So these just goes to show that none of the emotions are necessarily bad or like need to be suppressed, but rather sometimes the intensity can be very difficult. And with proper mental health treatment, as well as coping strategies and support, individuals can be very balanced, or children and youth can be very balanced in their emotions. And childhood and adolescence can be a very tumultuous time. And with support, we can really help the children manage these new changes that they're experiencing. So I wanted to ask, does anyone have any experience caring for a loved one with a mental health condition, and how has the parity law impacted your family?
Well, I can say that I have with my brother, but he didn't get any treatment really. I mean, he went to a therapist for a little while, but it didn't do him any good.
Yeah, I think that's another interesting point you bring up because I'm not going to really talk about this in my presentation, but definitely it's important to have a therapist that is a good fit for you. And I think with the limitations of current health plans, and limiting the number of providers that are in health care networks, I think that can be a barrier to finding a therapist that meets your needs, as well as different kinds of therapies, trauma, psychoanalytical, behavioral, and as well as culturally competent, culturally similar therapists. So thanks for bringing that up. Yes, Caroline?
Yeah, I guess I know a little bit from a family member, and I really don't know all the details, but I gather that they were forced to go I guess, go out of network, pay out of pocket, just because I know she had health insurance, but I don't think they could, you know, get coverage or find a provider. There was some sort of breakdown in the process, where it just didn't work. And I can also speak from the perspective of being a nurse, that I was the one who was on the phone trying to chase down somebody to help our patients because, they needed to see a provider. And, it was just like call after call after call, and they either weren't taking patients or they didn't take the insurance, or, there were just so many barriers to care.
Thanks for sharing.
Yeah.
Dr. Campbell?
Yeah, I don't have a family member, but I am a retired psychiatrist, and from my experience as a provider, and in Hawaii, the parity law works pretty well. I haven't seen arbitrary restrictions on benefits or not covering mental health services, but what I have seen is that when they introduced Medicaid managed care here, it drove all the psychiatrists out of Medicaid. We used to have just about 100% participation by psychiatrists, and it wasn't too hard to get somebody who could see your family member. But after managed care came in, they all dropped out. When I retired from private practice a few years ago, we could find only 2 psychiatrists in the whole state who were accepting new Medicaid patients, and they both ran medication mills where they would see you for 5 minutes every 3 months to renew your prescription and wouldn't talk to you. And that was it. And when they did that, our mental health emergency room and hospital costs shot up 30% over 4 years. It is cheaper to cover everything than it is to try to restrict it in hopes of saving money. You end up spending more in the back end when everybody ends up in the hospital without any outpatient options.
Yeah, well, that makes a lot of sense, especially I think with COVID and other kind of blocks to outpatient mental health. It really drives up like inpatient costs and emergency costs. All right, Dr. Dolkart.
Hi, Surbhi. So there's one issue of parity and there's another issue of payment. And I think I have a younger member of our family who actually did well in the state of Vermont with parity laws as they are. Each state is probably different. But nationally, the reimbursement for Medicare to clinicians and mental health providers is very limited. So if you have folks who are receiving therapy, the ability to find a therapist is actually limited by the reimbursement limitations. People just don't make a living being able to see patients who have Medicare. It's a little different if you have dementia, if you have psychiatric diagnoses. But so it is parity is different than payment. You might get to discuss that at some later this evening, perhaps.
Yeah, I will be talking about that. Even like disparities within private health plans, but I'll definitely be talking about the links between accepting Medicaid and then also burnout and the shortage of the profession more broadly. Any others before I move on to the next slide? Okay. So I wanted to talk about the current state of child and adolescent mental health. So about 1 in 6 children in the United States have some kind of behavioral health condition. And suicide is actually the second leading cause of death in adolescents ages 12 to 18. A recent 2019 surveillance report revealed that about 18.8% of adolescents considered suicide, like had suicidal thoughts and were thinking about it, and then 8.8% actually made an attempt. So it's actually a pretty severe issue. And then the COVID-19 pandemic has actually worsened pediatric health outcomes, where the emergency department visits for mental health actually went up by 24% for patients ages 5 to 11, and then they went up 31% from the age for ages 12 to 17. So there's actually a greater increase for the teenage population. And, it really kind of worsened that. And then there's actually a significant delay between initial diagnosis and treatment. I'm going to go into the reasons for this, but there's actually an average delay of 11 years between initial diagnosis and treatment. And this is actually from ages 15 to 54. So it includes both children or teenagers and adolescents. And the range of the delay is about 10 to 14 years. Part of the reason for this delay in the studies that I've found was people thinking that like they could do without treatment and they were kind of self-sufficient. But then, especially when that happens, things, emotions, things can build up, and that could lead to an emergency department visit, or a inpatient hospitalization. So that's something to consider. So I wanted to talk about the health disparities that are in mental health. So if you can see on the graph to the left, there are greater percentage of children, of Black children who have ADHD, who have behavioral or conduit issues, and who also have attempted suicide. And the interesting thing is that the white population has higher rates of anxiety and higher rates of completed suicide. So those are just some interesting things. Also, there are some disparities between urban and rural environments. There is a greater a psychiatric shortage in rural areas. And I'll talk more about that later, but you can see that in ADHD, behavioral or conduit issues, as well as completed suicide is higher in rural communities. And we also see here, this was a study looking at the time period of 2015 to 2019, compared to the white population. Black or African American, Asian, and Hispanic or Latino communities received mental health specialty care at a lower rate. A part of this can be due to the fact that mental health is still stigmatized in non-white populations and is slowly starting to get more accepted. I can speak for the Asian population. It is definitely still there, which is probably why it's one of the lowest out of all the racial groups. And then we can also see here within a Medicaid population, so access to depression therapy was also delimited by race. So if you're controlling for an income bracket, you can see that if you look at the third column, about only 55% of white people had access. So even that's still pretty low. Not everyone has the access. But then if you look at the white and Hispanic population, the Black population was about 42, and then the Hispanic population was 48. So it's actually less than 50%. This is an interesting graph studying within a low-income group. So I wanted to also talk about what are some of the main sources of insurance for this population, for the child and adolescent population. We have private insurance, usually through a parent. There is Medicaid through a parent if the family makes at or below the federal poverty line. I want to also bring up the fact that, especially in Massachusetts, you can work after the age of 14. So you may be if the child may be able to obtain health insurance that way privately. Also, number 3, CHIP, Children's Health Insurance Program. They offer a more generous eligibility compared to Medicaid. The income is at or lower than 170 to 400% of the federal poverty level. This is very state dependent. That's why there is a huge range. I also wanted to share that CHIP also covers pregnant women from the prenatal period, delivery, and postnatal period. And again, for that, the coverage can also be extended. And part of this is that we don't have kind of a CHIP equivalent for adults that are younger than 65. So this is something to consider when examining the rates of uninsured populations that I'm going to be talking about in the next slide. So here you can see that starting from 1984, the uninsurance rate for adults climbed up until 2000, 2012, it was like pretty steadily increasing, whereas for children, the uninsurance rate, it was like pretty constant, maybe a slight increase from 1984 to 1989, but it's been going down since then. And then in 2012, there's the implementation of Obamacare. So you can see that there is a really steep drop from 2012 to 2015 in the rate of uninsured adults, whereas for children, it's still kind of, the slope is very similar compared to previous years. And some of the limitations that like you can see from here is that it really, the uninsurance, it assumes that the uninsurance rate is kind of going to be constant in a given year, but individuals can kind of be fluctuating between different insurance plans, whether if they have been laid off or if they start a new job or if the family income changes, especially for children, they can be kind of fluctuating between different insurance plans. So it doesn't show that within a given time frame. So that's one of the limitation here. And then here you can also see like where predominantly the health insurance, where children versus adults get their insurance coverage. So children, it's predominantly through CHIP or Medicaid compared to adults. And then adults, it's predominantly employee sponsored compared to children. And there are higher rates of uninsurance in the adult population. And I wanted to also mention that this does not include individuals above the age of 65. So for that, I would assume you would probably have universal coverage under Medicare. And it's interesting that we have that for the elderly population where we have kind of a single payer system, but we don't have that for children under the age of 18. We have, the 3 private insurance, Medicaid, as well as CHIP. So it's just something to think about. And basically, there is a high unmet need for mental health in the child and adolescent population. So 1997 study, so this was long back, despite 15.2 to 20.8% of youth having a mental illness diagnosis, as per the study, only 6 to 7.5% of them received treatment. So that's about 20 to 40%, give or take. And then a recent panelist at an APA conference, Dr. Wes Boyd, who is a psychiatrist in Boston, he actually estimated that only 20% of youth and adolescents with a mental health disorder are in treatment. So this was in 2018, so this is about 20 years from the 1997 study. So really, there hasn't been much of a change in increasing access to mental health care for youth populations. I also wanted to stress that in that 1997 study, they determined that the rates of unmet need were higher in the Hispanic community and uninsured community. And as we saw in the graphs before, there was a higher rate of children being uninsured in 1997 compared to say 2012, 2016. So there's that correlation going on. And what are some of the barriers that adolescents face? So the top 4 barriers that you can see based on this table is actually stigma. So any barriers related to perceptions of mental health problems is at 23.3. You can also see that there 25.9% is any barriers related to the perception of obtaining mental health services. So it's really down to how other people are going to perceive them versus what are their philosophies and thinking about what mental health is. And the second barrier was actually thinking that the problem was not too serious. You can see here 17.2, so they decided to handle the problem on their own. And where was that? Excuse me. Sorry, the thought problems were not too serious was 20.7, and then decided to handle problems on their own was 17.2. And then the other barriers also above 10% was that the treatments were expensive. They really didn't have too much faith in providers. So the people they trusted most did not recommend help. So about 10% lack of confidence in who recommended help, again, around 10%, and the child did not want to go around 10%. So compared to children, adults have similar barriers. This was from a study in 2020. The biggest barrier for adults is cost. You can see it's about 46%. And then the other one was they didn't know where to go for services, as well as they think that they could handle without treatment, and then concerns about being of autonomy being taken away. We did want to mention that study in children, let me just go back to it. Sorry, I forgot to mention something. This was done in 2002, and they did another study actually in 2022, about 20 years later, and they discovered one of the other barriers that were also in that time were cost, transportation, lack of service availability, and inconvenient service times. So since about 20 years, I feel like there has been more awareness of mental health conditions, as well as a reduction in stigma. Although you can kind of see that based on this 2002 study, as well as in adults, there is some kind of stigma to obtaining some kind of treatment. The rates may have differed. The study really didn't mention stigma, the 2022 study, but there are some similarities and differences regarding the barriers between children and adults. For autism, based on a 2017 study across 5 private healthcare networks, youth with ASD are more than 3 times as likely to have some kind of comorbid condition, psychiatric condition. This includes ADHD, OCD, anxiety, depression. The neurological condition can be epilepsy. Because of this likelihood, they're more than 5 times they're more than 5 times more likely to utilize specialty services, including OT, PT, psychiatry, neurology, and there has been, the study did also mention that about 70 the rate of psychiatric comorbidities is about 73%, which is pretty high. And then, as I mentioned, in the general population, it's about 1 in 6. So some of the medications that they are also more likely to take. So overall, more broadly, the ASD population is 6 times more likely to take psychotropic medications. The top 3 medications are ADHD meds, antipsychotics, and antidepressants. Other medications also include mood stabilizers like lithium, benzodiazepines, and yeah. There also, I think part of this also includes, there are also some GI complications that correlate with autism, although the most common correlations are neurological and psychiatric issues. All right, so this is a study done among Kaiser Permanente. They wanted to look at the healthcare costs facing their ASD versus non-ASD populations. This was 2003 to 2004, so it is a little older, but I just did want to share it. So you can see here, based on the graph, that ASD patients across all age groups, across all pediatric age groups, had more than a doubling of healthcare costs. You can also see that as the age increases from 2 to 4, 5 to 9, 10 to 14, and 15 to 18, the costs actually go up. Whereas for the non-ASD population, there's actually kind of a fluctuation. So it increases from the 2 to 4 age, it decreases from the 2 to 4 age group to the 5 to 9 age group, but then it goes up again from 10 to 14 and 15 to 18. Unfortunately, with my own personal experience with ASD, as they transition into adulthood, the Department of Education and the government actually funds the living expenses, doesn't fund them as much as they do, as the Department of Education does. So there are additional out-of-pocket costs that families have to pay, and there can also be additional medical costs, as well as, lost wages, things like that. So there can be a variety of reasons for why costs are increasing. So I wanted to show here, like in what domains are the costs the highest. So as you can see here, the medication costs for psychotherapeutic agents, it's about 25 times higher. So this is
Surbhi,
the,
are you sharing screen? No?
yeah, do you see it?
I don't. Do others?
I can see it.
I see
Oh,
it.
sorry. Okay.
Oh, no problem. So you can see that the highest um, the greatest difference is for psychotherapeutic medications. As I talked about before, there's also disparities along the lines of gastrointestinal agents, but the psychotherapeutic agents you could see is the greatest difference in cost between ASD and non-ASD children. Other costs include inpatient hospital costs, psychiatric, again, 12.4 times higher. And then if you look at for psychology, sorry, excuse me, psychiatry and neurology outpatient visits, it's also the highest ones. And then ED costs, it's not as different, it's about 1.3, just slightly higher in the autism population. But I wanted to show that the costs are really linked to the neurological and psychological symptoms that a lot of the children with autism face. And tying back to the disparities in accessing mental health care among Medicaid and non-Medicaid populations, as well as providers not taking them, there's been a strong shortage of mental health providers for actually a decade, and this worsened during COVID. So what are some of the reasons for why this is happening? So there's a decrease in the number of psychiatry residency programs and a number of physicians who graduate in psychiatry. There's actually a lot of burnout. This is due to lawsuits, lower reimbursement for Medicaid patients, as well as community programs like shutting down because of these lack of funds. And clinicians report that when they are in these lower resource settings, there's a little bit lack of professional support. There's just a lot of, they're very overwhelmed with the caseload, and also a lack of resources. And there's also this, I found this very interesting. About 70% of the psychiatrist population, excuse me, is actually greater than 50. So you have a greater percentage of psychiatrists who are approaching retirement than are entering the profession. So you can see less than 40, it's about 10% of psychiatrists. So you can see that it's kind of professionals are aging out of the profession. So there's also, because of this, there's reported 18% of counties in the United States report having a mental health provider shortage that are like non-prescribing providers, so not psychiatrists, but all the other ones, social workers, psychologists, therapists, and there's actually a 96% shortage across all US counties of psychiatrists specifically. So there is a real crisis going on. And based on this, because of this, there is 2/3 of primary care pediatricians are not able to obtain a referral to a psychiatrist. And this is about 2 times higher than for other specialties. So for GI, palm, cardio, I would say together collectively would be about 1/3. And then this is 2/3. So that just goes to show how difficult it is. And a lot of there is a movement to try to address this by integrating behavioral health into primary care. But we'll talk more about that later. There are some limitations to that as well. There is, even within a private health insurance network, Blue Cross Blue Shield, this study actually revealed that there are still difficulties in accessing a child psychiatrist. So in this paper, the author acted as parents of a 12-year-old who needed mental health help, and they actually contacted 601 pediatricians and 312 psychiatrists. And this was in the Blue Cross Blue Shield network, and this was across 5 cities. And the surprising thing was that they could only secure appointments with 40% of pediatricians and 17% of psychiatrists. So even within primary care, like the majority of the time, they were not able to get an appointment. And they also reported a 30-day longer wait time to obtain an appointment with a psychiatrist. And the psychiatrist had very limited Medicaid appointments. So again, as Dr. Kemble was talking about before, there is kind of a limited pool of psychiatrists who accept Medicaid, again, due to the low reimbursement, as well as, there can be greater burnout as well. So that just also shows that even within private health insurance, there is still difficulty accessing services. Yes, Dr.
I
Campbell?
was going to say that in Hawaii, when they went to managed care, the psychiatrist reimbursement had always been low, but all of them took some Medicaid, usually like 25-35% of their practice is Medicaid. When they stopped taking it, it was not because of the pay, it was because of the managed care burdens of having to do all the prior authorizations and things like that. That's what drove them out. It wasn't the pay.
That's interesting. Yeah. So I think that can also be considered another kind of challenge for psychiatrists to take on Medicaid, is the kind of insurance bureaucracy involved with securing and getting reimbursed and providing care to their patients. So thanks for sharing that. Cheryl?
Yeah, don't you think part of it is also that psychiatry and psychology are both less respected than they were in the 60s and early 70s, before Reagan and the pull yourself up by your bootstraps, what's the matter with you attitude that became more and more prevalent? People didn't want to go into it anymore. And I mean, that to me addresses, I mean, is part of why there aren't more people becoming psychologists or psychiatrists. They don't want to be anymore. In the 60s, they really did, late 60s and early 70s. There was this Woody Allen-ish, everybody's got their analyst.
Well, I think that was true in the big cities, but when I got to Hawaii, there was no culture of psychotherapy being cool the way it was in Boston, where I trained. So it depends on where you were. But I also think that there may be something to changes in the level of stigma, but I really think the biggest reason that people stopped going to psychiatry is that psychiatry became most severely overmanaged by the Medicaid managed care companies in particular, and also by commercial insurance. We could see a patient for one visit, and then you had to get prior authorization to see 6 more, and then again to get 6 more on top of a restricted formulary. And so nobody wants to deal with that, and that's a large part of where the psychiatric problems are in the community.
Interesting. Thank you.
Dr. Dolkart?
Just to build on what Stephen just mentioned, there's articles in the New York Times and Washington Post about, even though somebody meets criteria for reimbursement, the insurers basically will retrospectively say, no, we're not going to cover this because they can with prior authorization. They're following their parity rules, but they're denying service even retrospectively after the patient's already been seen. I think the other issue, and that's typically therapists rather than psychiatrists. I think managed care affects all outpatient and pretty much every clinician. But I do think also that a lot of folks who might otherwise go into psychiatry can't pay their debt of $60,000 a year to go to medical school, so they decide to become a hospitalist instead. So I think there's a variety of factors playing these days.
Yeah, definitely, for sure. I mean, I'm also interested in why some of the residency programs may be closing and why there are fewer graduates. I know in my school, it's about 300 students and about 14 went into psychiatry. So it may be more of a demanding job than kind of what it looks like from the ideal kind of perspective. But anyways, So what's a single payer system? Sorry, I'm just trying to get this chat box out of the way. So this is a system where a single kind of entity, usually the government, they pay for the healthcare costs of a particular population. And theoretically, it can include copays, deductibles, although that can, again, create some barriers for low-income families. Um, and it's actually vastly less burdensome to providers to kind of provide services because you're only billing one insurance rather than multiple insurances. And you can also, I believe, have some kind of prior authorization for a single payer system, although if given like what like kind of what is there for like an average person, it may be less than private insurance companies. It's also less burdensome to patients and families to understand like what kinds of things are covered and to have to continuously like not change their insurance plans based on their income. And basically what I propose, well, actually, no, I wanted to hear about how you would design a single payer system to address pediatric mental health, and what are some of the factors you would include in this system? Yes, Dr. Campbell?
Well, you know, I have a ton to say on this.
Yes, you do.
But I would basically eliminate copays and deductibles. I think that it's okay to have a small copay for people who are not on Medicaid. But if you have an exception for people on Medicaid, that means you have to add the cost of eligibility determination to your single payer system, because you would then have two tiers. And I think that's not worth it. It's better to have no copay across the board so that everyone can be included on the same basis. I also think that because child psychiatry requires 2 extra years of training, child psychiatrists should get a higher rate of pay. Here in Hawaii, they didn't. And the child psychiatrists, when we started getting squeezed more by managed care and fees not keeping pace with practice costs, the child psychiatrist basically said, if I'm paid the same to see adults and kids, but with the kids, I got to deal with the family and the school and the guidance counselor and the courts and everything else, custody battles, all these things. It's not worth it. And I'm not paid anymore for it. So they quit seeing kids and would only see adults.
Wow. Yeah, I thought it was pretty traditional for if you did additional training to be paid more, but it's
In general,
interesting
it is,
that
but not for child psychiatry in Hawaii. And the result is that we have no availability of child psychiatry anymore.
wow. Yeah. So, does anyone else want to share before I describe my single payer system? All right. So basically, what I would do is, just like in line with what Dr. Campbell said, I would also recommend a single payer system with zero copays and deductibles, and this would be federally funded by our tax dollars and publicly administered, so not through like private companies or any ways that can kind of change the motivation from the public good to private to kind of gaining profits or profiteering. So that's why it would be publicly administered. And then also publicly funded and regionally administered. The reason I say regionally, oh, excuse me, is because I feel like it would be very difficult administratively to manage 50 states. But then if it's also just each individual state, I feel like there could be a lot of um, disparities from state to state, especially is because some states are very small, so the coverage could change within the span of like an hour of driving time. So I would definitely wanted bigger areas to be covered. So Northeast, Northwest, Southeast, and Southwest. And doctors will be reimbursed by the government. And that's how, like, for instance, that's how they would be billing each of the services that they provide. So as part of this plan, each region would have a workforce policy to ensure that are enough providers to meet the population needs. So a number of residency programs, number of graduates. As I demonstrated or I showed before, like the need and different rates of different disorders can vary across different races as well as different geography. So according to that, the providers will be trained as well as will be, that's how the need will be determined. And in the system, there won't really be a cap on which provider the patient wants to see. So they can see a provider outside their state, outside their region, with the benefit of telehealth, they're able to access a greater number of services. So that would be part of it. I mean, of course, they can go in person, but it would probably be difficult if the provider was out of region, out of state. There'd be zero deductibles and copays, as I mentioned before. And I think a really key part of this system would be a single EMR. So they actually have this, they implemented this in New Zealand. So the electronic medical record is like the property of the government, and then they distribute it to all the providers and hospitals. And I think this would be really key for improving communication, because every provider will basically be speaking the same language, and there won't be additional documents, sections, things like that that could be confusing. So it would really streamline communication between different providers. And I would prefer this system to be, this electronic medical system to be government administered and owned. And I also would encourage a greater amount of tax dollars to be devoted to mental health. So as of 2023, 2020, I did the calculation, and only 0.059% of tax dollars were devoted to mental health services. So this included ER visits, outpatient treatments, therapy, all of that. And I'm really not sure, based on the other sectors, how, if we would need to have additional taxes, or if we could take money from, let's say, where the government overspends and put it into mental health. But there would just be an increase in the number of tax dollars devoted to mental health. And it's really interesting, in Canada's single payer system, in which doctors are paid by the government, they have reduced income inequality significantly by 16%. So this plan would help reduce some of the disparities that we're seeing across class. Yes, Dr. Campbell.
I think there's more than enough money on wasted administration and management of care by corporations that are not nearly as effective in managing care as doctors are. You take all that administrative money, you take out all the middlemen, there's more than enough to pay for everybody to have access to care and pay doctors reasonably.
Yeah, so that could also be another.
Don't need to add costs. You can just take it from where it's being wasted and put it into actual care.
For sure, for sure. That's a really good thought. So I'm gonna actually be talking about this a little bit on the next slide with Taiwan. So let me just dive into that a little bit. So they established a single payer system in 1995, and they spend about less than 2% of their healthcare costs on health administration. They have a global budget, and they're able, through that as well as the system, to kind of check, do quality checks, regulation, and really work to improve care for citizens. So with this implementation, citizens have greater access to different providers. They actually don't even need a referral to go to any specialist. So they can just go to an orthopedic surgeon or a neurologist, just right without a referral. So it kind of reduces that bureaucratic complication. So this covers about 99% of citizens, and it covers hospital care, outpatient services, mental health care, Chinese medicine, and pharmaceutical companies. They do have copays and deductibles. Just copays. But there are no copays for mental health. They're all waived, which really shows that they really prioritize the well-being of their citizens. And the copays for medical services can range from 1.65 to 13.86 US dollars, depending on whether it was through a referral or without a referral. The ones that don't have a referral generally have a higher copayment. And the copays for prescriptions are capped at $6. And I was mentioning before, only less than 2% of the healthcare costs are administrative. It's about very comparable to Medicaid, which is about 2 to 2.5%, according to what Dr. Keller told me. Don't know the exact numbers. But then for private insurance, it's 15 to 25%. So it really goes to show you that when we have a single payer system, those administrative costs can really be diverted to improving patient health rather than spending on administrative costs. And the system is this is like really highly rated by Taiwanese citizens. About 83% of them, or excuse me, 73% of them, it's more than 50, are very happy and satisfied with their care. Some of the issues that you can have with this is that there may be a bit overuse of care if you can go without a referral. They may unnecessarily be seeing specialists. So it might be wise to have some kind of regulation on that. But overall, the citizens are very happy. Dr. Campbell?
On the administrative costs for Medicaid, Connecticut used to have Medicaid managed care companies, and they fired them in 2012 and went to the state taking on insurance risks and paying doctors directly. The administrative costs were 2%. If the state had the risk and didn't have any managed care companies, they were 25% with the managed care company. So that makes a big difference in the administrative overhead.
Wow. So it's
Yeah,
it's higher with the managed care.
Much higher with the managed care companies.
Surbhi, traditional Medicare is 2 to 3%.
Yep.
Medicaid varies by state, as Dr. Kimball was mentioning. Dr. Kimball mentioned, so it's very variable. But traditional Medicare as a single payer system, its administrative costs are 2 to 3%.
Got it.
Medicare, not Medicaid.
Oh, Medicare. Okay, excuse me. All right. So, beyond this, I feel like another solution that we can have is, as I spoke about before, due to the shortage of psychiatrists mainly, it would be vital if primary care pediatricians are trained to provide some kind of mental health support to their patients. So to really also kind of hone the point that it's estimated that there's a need for 30,000 psychiatrists, but then only 6,300 of them are in practice. And for children specifically, only about 15 to 25% of children are able to access specialty mental health care, but 75% of children can access primary care. So if we implement mental health support and treatment in the primary care setting, there is a way to reach a greater population, and possibly also underserved communities. And for milder symptoms, I feel like a primary care doctor can take care of that. But then if there are more severe conditions or comorbid conditions, like for example with autism, I think it would be vital if the pediatrician and the psychiatrist can work hand in hand to manage the care of the patient. And going along with a single EMR, that would definitely facilitate the communication across different providers who are caring for, excuse me, children with mental health, with complex mental health conditions. And one thing before I want to close, Dr. Marvin Malik, he actually talked about the benefits of having both pediatricians and psychologists and psychiatrists under the same roof in a community setting, where not only can the communication like through an EMR be pretty succinct, but it can also be very good like in person to have providers, all the mental health providers kind of under one roof, under the same network, coordinating care through the EMR in person, have like case presentations. So that could be another solution there to improve coordinated care. Yeah, that's my presentation. Any questions?
Yeah, I wanted to say there's a third way, which is collaborative care. There's really three ways for primary care practices, pediatricians to arrange for mental health care. One is to refer to someone in the community, but the severe shortages are a major barrier. The second one is to hire someone in your practice. But the difficulty with that is the person in your practice, either if you have a small practice, it's more than you need, or you only need someone part-time, or if you have a big group practice, the psychiatrist quickly gets full and then they're not very available anymore. Collaborative care is a psychiatrist paired with a care manager, is usually a psychiatric social worker, consulting to primary care practices through the electronic health record. And the pediatrician or the primary care doctor will refer the patient. The social worker will get a full history, talk to the patient and the doctor, review the chart, because we have a shared electronic record here in Hawaii. And then they meet with the psychiatrist once a week, go over the case, and the psychiatrist through the chart will give specific recommendations to the pediatrician on how to manage the case. This works really well. It enables the psychiatrist to leverage their time to cover a much larger population. The primary care doctors love it because they feel like then they have the confidence that they're doing the right thing because they have that kind of backup, and it's very cost effective. And you can cover a wider range of problems that way than you can with hiring somebody in-house. In fact, there are studies that show that collaborative care outperforms having an in-house mental health provider.
Interesting. Wow. So does the psychiatrist not, do they see the patient, like you said, once a week?
Oh, they don't see the patient directly. They go over the case with the care manager who's interviewed the patient, usually by phone or telehealth, once in a while in person, but usually indirectly, and then giving advice. The primary care doctor is the one who actually sees the patient and prescribes the medicines.
Oh, wow.
Surbhi, do you know if there are agencies, mental health agencies, that assess the requirements of a particular community? So hospitals under Medicare regulations will survey communities. There's area agencies that are mandated by law to assess a particular community's needs. And you mentioned regional provision of mental health, but also community provision is often important. I'm just curious if and you, Stephen, or yourself might know what agencies exist to assess we have a particular need for autism or a particular need for, substance abuse, etc.
I feel in a lot of the studies I was looking for, it's through registries. So I'm assuming that families probably volunteered to give that information to the organization. There's an autism mental health network. I feel like that was predominantly where most of the data was collected across, especially if they were doing it across multiple cities. And then again, Kaiser had their, like, it was already in their network, the patients, so they were able to kind of access that data right there. But I would say rather than having like kind of an experimental trial, a lot of this was more retrospective. It wasn't like giving a treatment and then a control group doesn't get a treatment. It's more of looking at data, what's already there, and kind of piecing through it. But if anyone else has anything, please, they can share if they know more about this.
I just wanted to comment that Dr. James Phelps here in Corvallis created a collaborative program like you mentioned, Steve, and I think it worked very well. He was happy. Primary care people were happy. And skipping over to the electronic medical record, the one we have now that has become such an industry epic is geared to billing more so than transfer of medical care, medical information. If Oregon, for example, develops its single payer system, we'll have to figure out if Epic can adjust from a billing centered system to medical information centered system. That will be a challenge, perhaps.
Like that's also like, I think with the new electronic healthcare records, clinicians are incentivized to bill that would generate kind of the most revenue for the company rather than what's medically relevant. So there's upcoding. So I think that, again, shifting from the perspective of kind of profiteering versus patient health, I feel like when that kind of changes, that will lead to better research as well as incentives to move from a coordinated care, collaborative care model where that is the main goal rather than upcoding. I think it's just the pressure on clinicians is just, I think that pressure may not always be in line with what they ethically believe and also like what they really first came to the profession to do. So that's an interesting point. Yeah, Dr. Huntington.
Yeah, I just am thinking back when I was at your level in training, and I am so impressed with your ability to take the time to research all of this. And thank you for an eloquent presentation.
Thank you so much. It was an honor.